Hi, good morning, everyone. My name is Wendy, and I'm very pleased to welcome you on behalf of the Global Mental Health Action Network and the UHC Working Group, together with our co-host, Unite for the Unite Parliamentarian Network for Global Health. And our theme for today's session is driving mental health into the UHC from political leadership to system implementation. And thank you for joining us during a very full World Health Assembly week. And really glad you guys are able to find this place. I know it's a hike to come here. And so there are many rooms and many conversations happening this week, and probably not enough coffee. So I'm really grateful that you guys are spending this time with us right now. And I also want to warmly thank the Unite Parliamentarian Network for Global Health for co-hosting this event. This partnership is important because the topic today sits right at the intersection of political leadership, technical guidance, civil society advocacy, and implementation experience. So in recent years, mental health has become much more visible on global health discussions. It is increasingly recognized as a fundamental part of universal health coverage and resilient health systems, also the inclusive development. So this recognition shows real progress, but recognition itself is not the same as implementation. And that is where the focus for today's session, and what does it take to make that commitment real in practice. And that means looking at financing, workforce models, service integration, governance, accountability, and continuity of care. And it means asking how mental health can move from policy language into the systems that people can actually access it. And this is why we are so pleased to have the political leaders, technical experts, and civil society representatives and our implementation partners in the same room today. And each of them brings a really important perspective. And the implementation experience can really show us where the real gaps are. So today we hope to focus on where the system got stuck and what decisions matters the most, and how different sectors can work together to advance mental health within the UHC system. And with that, I'm delighted to welcome Dr. Ricardo Batista Light, and the founder and president of Unite, and to share his opening remarks. Thank you.
Thank you, Wendy, and good morning. Good morning. Oh, wow. Okay, that's the best good morning I got in my third event of the day. And so I'm so happy. That shows your motivation. Although it's Wednesday, I feel like it's Friday, but we're halfway through. We're almost through WHA week. And I couldn't be happier to be at such an important event on such an important topic. As founder and president of the Unite Parliamentarians Network for Global Health, a network which is a nonprofit organization focused on bringing together members of parliaments, congresses, and senates today, more than 500 legislators from 120 countries that are committed to data-driven and science-based policymaking for the benefit of health for all. And therefore, to be able to partner with the Global Mental Health Action Network is certainly a cause for our gratitude, and therefore I'd like to thank the three co-chairs, Wendy, Pradeep, and Jacob. I'd also like to express a word of gratitude to the Unite chapter chair for Eastern Europe and Central Asia, Dr. Mariam Jashi, who will be joining us as a speaker throughout this event. And allow me also a personal note to thank all of the speakers, but in particular, I would also like to thank a very dear friend, Dr. Magda Rubalu, who is a former Minister of Health of Guinea and truly a global health advocate, and that we are very honored has taken time to join us today. Unite has been strongly committed in promoting legislation change in multiple fields of health. We are focusing now even more on the field of mental health. And the reasons are very clear. You're going to be hearing all of the data and stats. I'll just leave you with one because I think it's so important that it shows that 1 in every 8 people today are living with a mental health condition according to the WHO, making, of course, as we all know, mental health one of the leading causes of disability worldwide. Which means in this room, if you look around yourselves, 8 people is not a lot of people. And 1 in every group of 8 has some form of condition that one can consider a mental health challenge. And so it is truly a major problem. It is one that we know that many times health systems have tended to forget. And it's very easy to understand. If, you know, I'm a physician in infectious diseases, but I was in politics for many years as a member of parliament and in local government. And, you know, if you get on a bus and the bus driver has a broken leg, you get nervous, right? How is this guy going to drive? That's what you think. You think it's not safe. But you cannot see depression. It's not seen physically, but potentially there's risk. However, health systems have focused over centuries, if not millennia, on more of the physical aspects of health. And this has undermined many of our efforts when it comes to mental health. And so I believe from a policy perspective that the COVID-19 pandemic has been transformative in policymakers' perception of the severity of the situation, especially among youth, but across all populations. And so there are calls now from members of parliament from around the world. That's why Unite is also stepping up to integrate mental health into the concept of universal health coverage, of making sure that it is part of this wider umbrella of health and care that we need to provide to all. And therefore, to address this underfunded area of care, we have been focusing on building awareness, but at Unite, we are now focusing on political impact. To do so, we foster peer-to-peer exchanges among members of parliament. And I'd share one example of how in Ecuador, with the leadership of a Unite member, who is also an Ecuadorian senator, building cross-country discussions, cross-party discussions. As a nonpartisan organization, we foster cross-party discussions. The Ecuadorians were able to move forward their first mental health law, promoting a multi-sectoral and rights-based approach to mental health care and implementation. Of course, legislation alone is not enough. We need to make sure that what is the law on paper is actually law in action, but it's a first step. And then parliamentarians are responsible not just for passing legislation, they're responsible for getting budgets, and so getting the resources where they're needed, and they're also responsible for keeping governments accountable, of making sure they live up to the responsibilities. We here at WHA, so many governments, everybody's in favor of everything, right? And they sign all of these declarations. Parliamentarians then have to go home and make sure that they live up to the promises they make in Geneva and New York and elsewhere. And that's part of our mission. And our commitment at Unite has even grown further recently as we've created our first mental health policy desk led by my esteemed colleague from the Unite Secretariat, Lydia Bi, who's here today, and hopefully you will be able to engage with her. And the goal through the policy desk is to have within our Secretariat people who are focused exclusively on mental health policy change, supporting development and strengthening of mental health policies and legislative frameworks, convening national level working groups that bring together the different actors to foster dialogue, alignment, and practical pathways for improving mental health legislation. And this is already happening with a particular focus on the continent of Africa, and specifically in Portuguese-speaking countries of Africa, where we're very proud to also be present, many times forgotten among the Anglophone and the Francophone countries. And so we also feel that this is important to put some light where there has been too much shade. And so that is our role, to make sure that we bring light and hope in an area that needs more and more investment in the wider perspective of ensuring that universal health coverage is a reality for all. Policymakers, politicians need to be aware and need to be held responsible to make sure that the promises they make are turned into action. And I believe that is the main role we have here today, to make sure that no one is truly left behind. Thank you so much.
Hello, everyone. Thank you, Mr. President, for your address. My name is Jakub Bil. I'm a co-chair of UHC working group at Global Mental Health Action Network, and I will be moderating this discussion for you today. So the discussion will aim to identify the key system-level bottlenecks and strengthen collaboration across actors and highlight practical entry points for advancing mental health within universal health coverage across the dialogue and on accountability, legislative leadership, and sustainable system development. And we would like to ensure that mental health is not forgotten and that it's going to be, well, we hope it's going to be one of the key priorities for every single government and every single parliament across the globe. So for now, some of organizational issues. So we will be proceeding with our speakers, and after that, there will be Q&A session. So I will be trying to let everyone ask a question or make a short statement. So please, but please do not exceed 2 minutes for your statement or question from the floor. So let me welcome now our first speaker, who is Dan Chisholm. Dan is a mental health economist and from Department of Health and System Financing at WHO headquarters here in Geneva. He used to work also at WHO Euro in Copenhagen. So the floor is yours, Dan. Thank you.
Let's go up a level or two. Good morning, everybody. Good morning. Right, let's make that great to be here. Thank you very much for the invitation. Always good to be joining Global Mental Health Action Network events, UHC 2030, but particular shout out, I think, for Unite with the launch of their mental health policy desk at the UN General Assembly last year. So really thrilled that that's happened and is already taking shape, and I'll come back to that, how we hope we can support the work of Unite a little bit later. I actually need to make a little correction. I used to work as a health economist in the Department of Health System Financing, so I have to admit I am I'm a mental health economist. But actually, I work in we've gone through a huge restructuring, as many of you appreciate. The mental health department, as is now merged with the Department of Non-Communicable Diseases, and I work there as a health systems expert and specialist in that Department of NCDs and mental health. So I thought I'm well placed to say something about mental health systems, and I thought I could spend a few minutes saying why I think that's important, what it means, and how it can look in countries. So to start with the why question, I think we can think of several examples. If you take, for example, a policy or a plan that has been developed, but there isn't actually any strong implementation framework or a budget that's been put aside for its implementation, or the lack of targets or indicators. That's an example. Think of a deinstitutionalization plan where there isn't actually appropriate community-based alternative housing for people. Or a classic one is the training of non-specialists for identification and management of mental, neurological, or substance use conditions in primary care. But if you don't have for example, a law that enables nurses to prescribe medication, what's the value? Or if there isn't any medication, or if there are stockouts, people with epilepsy coming back for their medication, and oh no, we've run out. I mean, or indeed no referral or supervision structures in place. So these are all examples of how systems are not working well. There are gaps and fragmentation, missing parts of the puzzle, which mean that there are failures ultimately in service delivery. So I think a systems approach, we move to the second question, the what does it mean? I think a systems approach is all about seeing the bigger picture and the interconnectedness between those different parts of a service, of a system, what is needed in order to make the ultimate goal or objective of the system or the service apparent. And indeed, I think sometimes there's even real clarity about how the different parts of a system are all working together towards a unified goal. Let's say that's expressed as improvements in service access. That's the new target, for example, from the UN General Assembly political declaration last year. So 150 million more people with access to mental health services. So that's a clear objective, but how are the different parts of the system all, aligned to make that most likely happen? And a systems approach is all about moving from a kind of a siloed, short-term, sometimes sort of project-based approach, often at making marginal improvements and changing to a much more holistic, program-wide, more like a whole transformation, system transformation, linked to broader health system strengthening or reform efforts or UHC reform efforts in a country. And the final point about the systems approach is that it's not linear. We often think in linear ways, we have to do this, we have to do that, and then that will happen. It doesn't quite work like that. It's much more complex, and something that, you think needs to happen actually needs to go later. And, there are these different moving parts, basically, and it's complex, and we have to accept that it's complex and will take time. A systems approach is not about getting quick wins. So that's what I want to say about the what. And then my third bit is about the how. How does it sort of end up looking in practice, this bit, the system implementation? And I do think it does start with the leadership and the policy. But even before you have policy dialogue and engagement, it's really important to understand what the barriers and constraints are to improving mental health services and systems. So it's important to have time, countries to have time to sit back and reflect and look at that. Next week, for example, in South Africa, there's an inter-country meeting of many of the Southern African, Eastern African countries who will be doing exactly that. They've been doing some landscaping of their current situation with the intent of identifying and sharing what they see as their main mental health service and system gaps and constraints. And maybe through that, we will identify some common themes and issues. I think we can guess what some of them are. But having that pause for reflection is important, because then it enables you to approach policymakers and parliamentarians in terms of what are the gaps, the needs, the opportunities, the constraints, and having a clear approach. And that might take time. There's a WHO special initiative for mental health that's been going on for a few years now, and we've achieved great things, but in some other countries, it took a long time to get going. Bangladesh stands out in my mind. It took maybe 2 or 3 years. We're going to think, oh, we're spending this money and supporting them, and we can't see any change. But it took that level of engagement. It just took the time, and before they were ready to move, and now they're moving. And so you've got to be patient sometimes. A second one is around the principle of governance and having clear, and so I say the word disciplined plans, because often we read mental health strategies and plans that are promising everything under the sun, but then, as I said at the beginning, they're not actually aligned with reality or with the resource constraints or other system constraints. So having a disciplined plan, which ideally is costed, and signposted along the way for monitoring progress. And then we come to legislation. Legislation is super important, but it's a good example of something which takes time. It's not, as Lydia and I were just discussing before, you know, they're starting the process in Cape Verde, and already it's several months, and it will take many more months before that would be able to, you know, come to the Parliament for decision. And so I think this is an excellent way in which, this is very exciting to see UNITE working and focusing its attentions on mental health and particularly legislation, because parliamentarians are so obviously important. But I would say it's also an example, law. It's not just about human rights standards and protecting those human rights through ethical standards of care, but I think laws can also be very supportive of system change, whether that's financial protection coverage or service reorganization or provider accreditation. These are all examples where, you know, the policy can be supportive. And I would say the same about things like health financing. Really good example in places like Ukraine, which have done incredible work in the last few years to align some of the UHC and health financing reforms in the country. They've aligned that to the mental health reforms and use the health financing to incentivize and change the mental health system through the way that they contract services and also incentivize providers. For example, if you as a primary care provider do an MHGAP, WHO MHGAP training course, you get a kind of certificate which then enables you then to have people on your caseload. And they've reached virtually the whole country. The coverage change in access to services is simply remarkable. And then a couple more things, and then I'll pass on to the next speaker. The whole issue of access to medicines, I think, is a whole system in itself, right? We think about it, everything from the purchasing and prescribing and the pricing. All of these issues need to be seen in that system's way. Otherwise, you know, you have these problems of stock out or inappropriate prescribing practices and all kinds of other adverse outcomes. And then the final piece is always around information and data and monitoring and surveillance. And all of that is really important for accountability. So it's often something that we see as being very weak part of the mental health system is the level of data and information flowing through it. So this is an area which we're specifically trying to strengthen countries' ability by identifying a key set of indicators that can be collected and used in routine healthcare and thereby reported on. So that's the kind of the how. And to conclude, I would say that you know, we have basically lots of frameworks and we have lots of tools, lots of evidence, lots of expertise from WHO, from many other partners as well working in this space. And we have a lot of interest, we have successes, we have some failures also in countries. But ultimately, it is about a political choice to whether to do something about mental health or not. And doing something about it means that you have to take it seriously. It's a transformative effort, not snipping at the corners, but taking a good hard look at the situation and then systematically thinking through the different components that need to be improved over time. And of course, we will be very happy to work with the countries and working with UNITE, hopefully in some of the Portuguese-speaking countries in Africa. I know you're intending to use our legislation guidance, and I'm already en route to getting that translated into Portuguese, because I think that's a fundamental requirement if that's going to be a particular thing. So with that, I'll stop. Thank you.
Thank you very much. Of course, I need to apologize for my mistake while introducing you. So, accept my apologies. And now I would like to ask another speaker. Let us introduce, well, I would like to introduce to you Dr. Magda Robalo, co-chair of the UHC 2030. Please.
Thank you very much for the opportunity. Good morning. Good morning. I didn't hear you. Good morning. Good morning. Okay, good. Thank you. Thank you. I want to thank Unite, the network of parliamentarians for global health, and its founder and leader, Dr. Ricardo Batista Leite, for inviting us and co-organizing this important event with us. And I want to thank the Global Mental Health Action Network for also inviting us and for convening this important discussion. The title of this session, Moving from Political Leadership to System Implementation, captures exactly where we are on universal health coverage. Mental health has gained increasing political visibility in recent years, particularly after the COVID-19 pandemic, with many countries adopting national strategies, policy reforms, and broader commitments to strengthen services and expand access to care. But a very persistent implementation gap remains, as you have heard from those who preceded me here. It is estimated that more than 1 billion people globally are living with mental health conditions, which remain among the leading causes of disability worldwide. More than 720,000 people die by suicide every single year, and suicide remains the third leading cause of death among young people aged 15 to 29 globally. Just before coming here, I was in another meeting where an important partner in the global health ecosystem has just redesigned their strategy, and they are going to focus on young people. And part of the conversation was about mental health, to really make sure that mental health is not forgotten. Despite the growing burden, governments globally spend on average less than 2% of health budgets on mental health. And in many low and middle income countries, the majority of people still do not receive the care they need. Yesterday, I was in this very same room, and with Ali, we also touched on issues related to mental health. The good news is that universal health coverage is now firmly on the political agenda. The Act for UHC 2025 report finds that 90% of WHO member states have national health policies, strategies, or plans oriented toward universal health coverage, and 86% have measurable UHC targets. Yet commitment is still not translating quickly enough into equitable access, quality services, and financial protection for all. Dr. Ricardo Batista later reminded us that when 190 plus member states come to Geneva for the World Health Assembly, they agree on almost everything that they will do, and they pass resolutions. When they go back home, parliamentarians need to transform those into laws to be implemented, and this is where we have a huge gap from commitment to implementation into laws that make implementation work and support the people that need the services we commit to provide. Progress has been made, but it has slowed. 4.6 billion people still lack full coverage of essential health services, and I keep on reminding all of us about the aim, the goal, and the purpose of the reform of the global health architecture we have embarked on. It is not just about fixing the pain points we have right now. It is making sure that we bring on board those who have been persistently left behind. And that's 4.6 billion people. That's half of the world's population. That's a lot of people not to be covered by basic health services. 2.1 billion people experience financial hardship due to out-of-pocket health spending. And the burden of financial hardship disproportionately falls on people living in poverty, with 1.6 billion people pushed into or deeper into poverty because of out-of-pocket health spending. And if we continue at the current pace, unfortunately, the world is not going to achieve universal health coverage. We are not even going to be on track to achieve the goal of universal health coverage. This is why the focus for the future cannot simply be expanding coverage. It must be building much more inclusive health systems for greater health equity, for more equitable health outcomes, and the realization of the right to health for all. An inclusive health system is not measured only by who is covered on paper. It asks deeper questions. Who's still not covered? Who's still not reached? Who's facing barriers to care? Who's invisible in the data? And who's excluded from decisions that affect their health? For people needing mental health services, these questions are so important. Despite the growing political recognition, implementation remains uneven. In many, many countries, mental health services remain fragmented, with limited integration into primary healthcare services and persistent barriers that undermine continuity of care. Such barriers include stigma. Mental health is still not something that we talk about easily. It is still very much a condition, a wide variety of conditions that we are still not comfortable talking about. And that's one such barrier that we need to remove so that people can reach out for services where services are available, and where they are not available, they are established because people are demanding services. Despite, as I was saying, despite growing political recognition, implementation remains uneven in many countries. Mental health services remain fragmented and little integration into primary health care. The barriers, in addition to stigma, are cost, discrimination, distance, waiting times, shortages of trained workers, poor quality of services, and lack of continuity of care. These challenges are often compounded, like I said, by stigma and by systems that continue to concentrate care in specialized institutions, in specialized settings, rather than bringing services closer to communities. Financial protection is also a matter of equity. People living in poverty often face overlapping burdens. Poverty increases exposure to mental health risks. Mental health conditions can reduce income and employment opportunities. And when services are not publicly financed, people may delay care, pay out of pocket, or go without care entirely. The opportunity that we have is therefore not to create a separate agenda for mental health, but to strengthen health systems so that they become more inclusive and responsive to people's needs. We need to call on member states to take urgent actions. They need to remove barriers to access, identify and prioritize those being left behind, institutionalize inclusive governance through social participation, reorganize services around quality, integrated primary health care, strengthening the health and care workforce, and reducing financial hardship. When health systems are reorganized around integrated quality primary health care, mental health services become easier to access. They become closer to communities and less dependent on fragmented specialist systems. If we remove financial barriers, people are less likely to delay or forego care because of cost. When countries collect better disaggregated data, they can identify who's being excluded and design responses that reach populations too often overlooked. And when communities, civil society, people with lived experience and frontline workers participate in decision-making, services become more responsive to the realities people face. Mental health is not separate from the UHC agenda. It is a test of whether our systems are truly inclusive and people-centered. Because UHC is not about only covering more people, it is about building systems that uphold dignity, advance equity, and make the right to health a reality for everyone. I thank you.
Thank you very much, Dr. Raballo. Now I would like to invite our next speaker, Dr. Mariam Yashi, who is United's Global Board Member and former parliamentarian and Deputy Minister of Health. Here you are, the floor is yours.
Thank you. Delighted to join the audience. Thank you so much for the invitation. Thanks to Unite, Ricardo, Guilherme, our team, our colleague from Egypt, Member of Parliament, and Amira, and the Global Mental Health Action Network for organizing this meeting. Very frankly, I don't feel myself as the best expert in the field, especially when we are present with the leading thought leaders in mental health, including Judy Kuriansky, my dearest friend from New York, who especially joined the side event today. And thank you very much for joining us, Dr. Kuriansky. From the perspective of policymakers, I would like to emphasize some of the policy and implementation gaps. It's great that mental health has already achieved political recognition at the highest global health. Okay, thank you so much. At the highest global health architecture and political commitment levels, but we have to really move beyond political recognition of the issue. We're better than where we were before, like 2 or 3 decades ago. But when we really touch implementation aspects of the area, mental health continues to be massively underfunded. Governments are allocating only 2% of health sector spending. We have massive inequality in funding mental health issues. For example, if high-income countries are allocating $65 per capita, we're talking about few cents in low and middle-income countries. Less than 10, Magda Raballo already mentioned that less than 10% of those in need of mental health services have access to affordable and quality care. Less than 10% of member states have really shifted the focus from institutional-based mental health care to community-based approaches. And someone who was born in Georgia, part of the Soviet Union, I can assure you that mental health services were extremely closed and institutionalized, and one of the reforms that Georgia is proud of is deinstitutionalization of care. We're not yet there for full universal coverage of community-based and continuum of care for mental health, for people and caregivers affected by mental health, but progress is definitely there. Today, I'm also representing two organizations, the Medical Women's International Association, and 4 of my colleagues are also in the room, representing Canadian Medical Women's Association, American Medical Women's Association, and Indian Medical Women's Association. We bring 106 years of legacy and 12,000 female physician representation in more than 70 countries. And within the medical field, 72% of female physicians are experiencing depression, and more than 50% are experiencing burnout due to their professional engagement. So mental health aspects of women in medicine is also extremely important to consider, especially in provision of adequate care to our citizens and communities. And finally, as the CEO of the Global Sepsis Alliance, sepsis affects 11 million people every year. 1 in every 5 deaths is related to sepsis, and those who are lucky to survive. And under lucky, we may mean conditions where people may lose their legs or hands or continue to live with life-changing disabilities. And mental health issue is extremely important in sepsis survivors and their families. So when we speak about universal health care and when we speak about leaving no one behind, we're not only speaking about women, children, and men whom we serve as our constituencies, as our patients, but we're speaking about the women health workforce who has to secure the fundamental strengths of the health system and have to ensure that mental health indicators are also seen in UHC progress indexes. If we don't measure how we can make a difference. So my call today is that we continue to work on very specific tracer indicators that can give us a better possibility of measuring, tracking, and improving the status quo. Thank you very much.
Thank you so much. And now I would like to invite our last speaker, Dr. Manoj Kurian, Director of the WCC, Commission of the Churches on Health and Healing. Here you are. The floor is yours.
Thank you very much. Thank you very much. Thank you to Unite and to the Global Mental Health Action Network. We have been closely working with both of you. Dr. Ricardo has reached out to us, and we have worked together on artificial intelligence and healthcare, and of course with the Global Mental Health Action Network, we have done various programs and webinars together. Really, really thank you. Of course, I'm not speaking from a faith-based perspective, but from a community perspective, broader community perspective. And you know, I'll just give a few thoughts preparing you for the, you know, because I think a lot of very key issues have been mentioned. So I will not go into the statistics and or the horrific situation we are facing, but just to be in touch with you, because just to confirm what all that you have said, we see the impacts on the ground. A couple of years ago, the police department in Malawi had reached out to the churches, alarmed by the rate of suicides. In South Korea, in Switzerland, you know, when you travel in train, the train stops occasionally. They will say it's because of human interference. It's actually people jumping out onto the tracks, and they find it difficult to retain train drivers. They have to have psychotherapy. In South Korea, in Seoul, there's a big bridge, you know, and there is a speedboat located below it to pick up people who are jumping to kill themselves. I went to Namibia a couple of years ago. We were closely with all these countries. You know, it's a country of 3.5 million people, middle income. There are about 17 health professionals, and 3 people kill themselves each day. So this is the tip of the iceberg. It's huge. It's huge. But, you know, in the context of the World Health Assembly, I would say that we have two big deficits in the world in healthcare. One is a financial deficit, and the other is the trust deficit. And you know, we, as you parliamentarians, you represent us. We are with you as countries. You are representing us, and so you know, we are not saying that, you know, we have to work with you, and your success as our champions who are sensitive to these, and from global the Global Mental Health Action Network, bringing all the mental health professionals together, and of course World Health Organizations, who is the apex body, go in spite of all these challenges they're giving us, they're doing their best. How can we actually bridge these gaps? See, if you look at the global wealth in the world, I mean, the public wealth over the last 3 decades have declined. And the private wealth is huge. So, you know, we are talking about public-private partnerships and all these things where the governments and people have lost complete control over most of the resources and businesses. So you as parliamentarians actually don't have much power. And health professionals who are dealing with mental health professions don't have much power, because you have hardly, of course, everybody recognizes mental health, but with pittance of... So how do you actually solve this to gain this trust deficit and financial deficit? I think it's only by reaching out and actually, you know, working closely with the communities. Because the communities are the people who give you your mandate. And they are the people who actually can demand. And they're not there just to implement your programs and to you know, kind of passive recipients of your brilliant schemes. You know, they are the people facing all these challenges. They are your bosses. You know, the word minister means servant. We have forgotten that. Even the churches have forgotten that. We have our bishops and all this, with all their splendor. They are supposed to be serving ministers. So we have to serve our community and actually listen and engage them. And this huge power in communities. There are, you know, I can tell you, we are in the process of trying to mobilize, because there is a huge gap. We cannot actually train all our people. There is so much of deficit. You know, each country of millions of people have a few hundreds of, or 20, 30, they're not even in 3 digits, the mental health professionals. The only way is to actually that we work together to engage them. How do we actually equip them? How do we, that, you know, the knowledge and dialogue, and we have to reach people where they are. You know, you can't just say, okay, when they say they are demon possessed, rather than going and say that, you know, there is no demon possession, you have to start with those people who think there is a demon, and how do we actually get this demon out? You know, you have to start from where people are. And there are communities where they don't believe in anything. So we'll have to start from their rational perspective. There are a lot of good examples. I will not, I can share a lot of stories. You can actually think back how, because we want our communities to be healing communities, therapeutic communities, not, you know, our faith communities, our communities not to become centers for gossip, but rather safe spaces. So what are the standards? Standards of caring for ourselves, caring for each other. So, you know, in your programs, how are you caring for your health workers, as the doctor was saying? Our pastors, they're dying. They're dying either of chronic diseases, or they're completely dysfunctional because the burdens are so huge. So, you know, it's a dialogue. And you need to have the dialogue at your community level. Do you actually see us here? So, you know, one of my bishops one day went to a church in rural, I'm from Malaysia, but I'm of Indian ancestry, so I worked many years in rural India. So he actually asked the church, he's a very, very wise man. He said, you know, if this church disappears today and the coffee shop across the road disappears today, which institution will this village miss? Is it your church or the coffee shop? So it's a very important question for us to ask. If my department, if my government, if my organization, my church disappears today, will that be felt? Actually, it's a serious question because there's a huge question of credibility of us going back to the basics. Are we listening to ourselves? Are we listening to our children? I don't want to give all, but I think we have to ask this very seriously. And I'm speaking for communities, not just faith communities, any community, people's movements. You need to get back to your powerful backers. They are your people. And why we are facing all these tumultuous situations in the world, in Europe, in North America, all over the world, is not because people are bad or because politicians are bad. They're just symptoms of a system where people don't feel heard, innovations don't reach, and there's a trust deficit, finance deficit. And finance, you can just forget it. You don't need money. You need people to invest their time. You don't need a lot of money to heal. You just sit around and be patient. So what I'm trying to say is you need to mobilize the communities. And that can only be done by engaging communities. I'm sorry, I'm very generic because I don't need to get specific because you are all coming from communities. You can just close your eyes and reflect something that has made a huge difference in your life, in your community, maybe with the workplace, with your institution. How have you connected with people? What we say, what spirituality is, if you can feel something beyond you. When we see evil, what is evil? Evil is a break of relationship between each other, between principles. And if you so get focused on what you do and you're not connected with others, that is evil. It's like running the race the fastest you can in the wrong direction. You may be the fastest runner, but if you run in the wrong direction, we will not reach the destination. And that's where we are. We are very efficient, we are very lopsided, we are very smart, but we are disconnected in this very connected world. So I'll pause there and then invite you for discussions. Thank you.
Thank you very much, Dr. Kurian. I would like to now invite all speakers to the table. So we would have the session of questions. And as we've heard, please take a seat. And as we've heard from our speakers, we've heard about the whole variety of problems that we are facing. We've heard about solutions implemented by the WHO. We've heard about what shall be done, what members of parliament can do. However, I have to admit, I'm gonna change a little bit what I wanted to say because Dr. Manoj Kurian inspired me to ask the first question to all panelists. As we define universal health coverage as really universal, so to what extent do we think about those who are not covered by their social security number, about those who are out of the system totally? Because we have millions of people facing that every day, including children and young people. And within our world, most of those who do not have social security number or whatever it is called in their countries, their access to mental health care is zero. So what are your thoughts? Yes, please go ahead, Dr. Yashi.
I think that this is a very important question, and we can agree that universal does not always mean universal. And the closest definition of universal health coverage could be also the statement within the WHO's constitution requesting member states to secure the best available standard of health care for their citizens. And unfortunately, due to resource limitations, capacity limitations, workforce limitations, or stigma and discrimination elements, that best attainable standard of care differs from one country to another. Even if you look at the packages of universal health coverage for different countries, they differ. But the positive side is that once governments agree on the basic initial foundation of universal health coverage, it can be a continuously expanding list of services. And while, yes, most of the universal health coverage packages do not include mental health components, apart from maybe postnatal component of care or referral of depression or other mental health conditions to the upper level of care. And many of the, as I said, in many countries, mental health services remain as vertical rather than fully horizontal and integrated in the programs, not only because of funding or availability of healthcare, but lack of infrastructure, both physical infrastructure and human resource infrastructure. And as UNITE is supporting through the mental health desk development and scale up of comprehensive mental health policies, I believe that is the platform where we could coordinate better. And of course, Lisbon Secretariat and our colleagues working on the mental health aspects are ready to support that effort.
Thank you very much.
Yes,
let us our panelists go first, and then we will move to questions from.
Thank you. Just to add again on the issue of universal health coverage, I want to insist on the importance of reforming the health sector in ways that we truly focus on primary health care, because the siloed nature of investing in specific diseases meant that critical areas were left out, number one. Number two, it meant also that people are provided care based on the disease of the moment or the pain that brought them to the health system. Yesterday, I listened to a testimony by a cervical cancer survivor, a woman from Kenya who was HIV positive to start with, then developed cervical cancer, then developed colorectal cancer, then another cancer, and then she was being seen by bits and pieces depending on what brought her to the health system rather than a comprehensive and holistic approach to a person instead of addressing a disease at the given point in time. And this is what is happening with mental health. If the world continues focusing on infectious diseases, and if we shift to non-communicable diseases, we address diabetes maybe or hypertension, rather than looking at the person as holistically and people-centered care, we will not have enough resources to invest in health systems. So an integrated approach, that's the way to go. And all of us in this room and outside of this room should be advocating for the 4.6 billion people who currently don't have access to basic health care to be included, and to make sure that we have people-centered approach to care. If not, in 20 years' time, we'll say, this system is broken, well, we need to reform, and then we start all over again. Thank you.
Thank you.
Same question?
Yes, same question, please.
Difficult question. I think Dr. Mariam mentioned the very low level of current coverage. I think it was part of a study that was established that the treatment gap for depression is around 90% globally, and of course even higher than that in many low-income countries. So even that has some information value, demonstrating the extent of their unmet need, and often that's not known. Countries are not aware just of the extent of the information gap, the treatment gap. A second point is that from the economic perspective, we do a lot of work to demonstrate and have demonstrated that mental health care, mental health services, mental health essential medicines are not expensive. They are. It's not a question of affordability. We are not talking, revolutionary high-tech technologies in most, with a few exceptions. It's essential care and services and products, health products, are affordable. They're cheap. The problem is that the people who end up paying for those products are households and individuals, rather than through the public purse. So there's an inherent equity problem underlying the financing of mental health services. And of course, there's also the issue of access and availability. In many parts of many countries, there are no mental health services. If you want to go to get some treatment or care, you may have to go hundreds of miles to a hospital at great, again, cost to the family. So I think the reality is that the approach to overcoming that treatment and service gap is incremental. If we're starting at 5%, 10% coverage, and we want to reach 5 or 10 times that level, that's going to take time. So it's going to require a very determined, dedicated systemic approach to overcome that gap over time. But even having a clear plan about how you can go about that is already an important first step. And my final point would just be around stigma. This is always my view that stigma is the real problem because it affects policy making, it affects resource allocation, it affects also the demand for services and help-seeking behaviors. If you don't dare go out to seek services because of the stigma it might bring on you or your family, that in itself then buries and makes the demand, masks the underlying need and demand for services. So I think that's where addressing stigma and perceptions and attitudes around mental health is, again, a very cheap thing to do, but a crucially important one.
Yes, thank you for this question, and thank you for my panelists for very insightful responses. I could add that, I think from two perspectives. One is, how do you judge civilizations? Is it the language or the beauty of the literature? Is it how beautiful the places of worship are? Or is it how good, what a football team you have? I think it is how, in my understanding, it's how we treat the least, the most vulnerable persons of our community. And unfortunately, in a democracy, they don't have much of power. So it should be a very, very important measure and to see who are those, and each community will have its own marginalized communities based on our own stigmas and approaches. Could be anyway. So just that point. So I think we have to keep checking how are the least in our communities faring, and if they are not, and don't try to paper over it, because of we don't want bad news. We self-censorship. We should not do that. We should be, first of all, acknowledge the problems we have, however small it is. And, and I say, if we call ourselves as one body, one community as the world, we know it is one health. We are one body. And if you have one body, if one hand is in water and the other hand is in is in fire, I cannot say on an average I'm fine. There are no averages actually. Even what's happening in Ituri province, you can't say an average. Just because they don't look like you, it doesn't mean that it's not a problem. It's a huge problem because one hand is in fire. Now, the second aspect I would like to say is that, the one crucial problem of what UHC does not say is about community engagement sufficiently, as much as primary healthcare. We have to engage the community. It is not that you're going with a package of things. They have a lot of resources. People actually who face the challenges, are the people who have the solutions. So I've worked extensively in Africa, but I've never run the program, in HIV, because I always engaged people in the continent. I said, I cannot decide for you. I'm just here as a facilitator. So we have to engage the people, and that is so important because, they have so much of agency, so much of energy, and we have to listen to their solutions. And from the spiritual perspective, there are only 3 pillars of health. One is, do you have sufficient rest? Second is, what do you consume? Consume not only eating, what do you read, how do you spend your time? And 3, what is your activity? What do you do with your life? So we have to address all this in a very holistic manner. It's not rocket science. It's not rocket science. You cannot go to a community in an arrogant fashion doling out medicines. You have to literally go on your knees because they are the people you serve and they have more than half of the solutions. Thank you.
Thank you very much. Just before we start our questions, I would like to invite you to watch absolutely brief address from our co-sponsor, World Federation for Mental Health. And that's going to be addressed by former President, Professor Tsuyoshi Akiyama. It will last 3 minutes. And then I will ask the audience to ask questions. Thank you. Here you are. I'm trying to launch the video.
Greeting from Tsuyoshi Akiyama. Distinguished parliamentarians, colleagues, and friends, on behalf of the World Federation for Mental Health, I express our sincere appreciation to the Unite Parliamentarians Network for Global Health and the Global Mental Health Action Network for bringing us together. Universal health coverage is one of the most important global health commitments over time. However, universal health coverage cannot be achieved if mental health is neglected. Integrating mental health into universal health coverage is not only a health priority, it is a human rights, social justice, and even economic issue. As a Japanese citizen, I'm proud to note that Japan hosts the Universal Health Coverage Knowledge Hub. The WFMH supports the joint efforts to advocate for mental health as an essential component of universal health coverage. Together, we can build health systems that treat mental health with the same commitment, urgency, and dignity as physical health issues. Thank you.
Thank you very much. Now, shall we go here, lady in the third row? Please, can you pass the mic, pretty? It's not on.
Hello. Thank you so much. Good morning. I'm from Spain, so I'm mental health nurse. So you expose different key points, key important views, no stigma, percentages. But I want to say that we have to drive more mental health for the implementation on the healthcare system, because sometimes as a healthcare workers, unfortunately we work separately of the politicians. So for that way, I think we have to integrate more healthcare workforce in the decision making tables. No, for that reason, I wanted to ask you, how can we move from political leadership to effective implementation on the ground, because we have this gap on the ground, ensuring that all healthcare professionals involved in delivering care we are engaged in the process. Do you think that our political leaders willing to share decision making with frontline healthcare professionals, or do we continue to confusing consultation with new co-designs in the implementation of the healthcare system? Because as a healthcare workers, I think maybe we are not linked with politicians in the decision making for achieve the quality of care and the implementation of the different mental health programs to respond to the reality of the necessity of our patients. So I think it's a big gap that we have in this moment. Thank you.
Okay, so let's take the next question, please, sir. Yes, we will take 3-4 questions, and then we're going to ask our panelists to answer. Please go ahead.
WHO was established in 1945, and they gave the first definition of health: physical, social, and mental health. But if you look at the first half century of WHO, the focus was much more on physical health, very little on social, and mental health came on the board much later. And that could be one of the drivers for this kind of late start with the mental health issues. Second is, I did my medical degree, and I remember when I was doing the degree, psychiatry was one of the lowest liked, what you call is a clinical discipline. So there was a stigma issue not only with the clients, but also within the provider community, that the best of the students will not go to psychiatry. And I think the turning point was during HIV, when the stigma issues were taken upfront, and that cascaded down to other issues like mental health. So I haven't asked any question, but I would invite any reflections.
Thank you. So please go ahead.
Thank you. Rosa Maria Rios, from Women in Global Health and Health Ministry of Spain. Continues of the approach of Dr. Arroballo about how to approach the mental health. I think we have an opportunity, a window of opportunity, to approach a real universal coverage. In 2023, we analyzed all the pathologies of mental health around the world. We don't have data, but also we analyze by sex, and we see that mental health who affect women was not linked about illness, it was more linked about psychological space. One of the things is we need to approach in clinical, it's true, and especially to support the care drivers in the clinical pathologies, but also we need to approach in prevention, because there are a lot of things we can do in prevention. For example, in the doctors, you say burnout. There are a lot of data we have about psychological exposures that we can work and not arrive to put a psychologist in the health workers maybe to work. Okay, thank you.
Thank you.
Thank you. This is a very important issue, and I'd like the panel to address tying some pieces together for me. It's related, first of all, to this umbrella that's an elephant in the room that started this whole campaign way before COVID about universal health coverage and everybody being under it. So at that time, thank you, Georgia, because Georgia, Mariam, your country, and Thailand were the co-facilitators of the political declaration for universal health coverage long ago. So this is point one that I want to tie this piece together with this conversation, because I haven't heard that yet talked about here, and that's a foundation. The second foundation is Mexico's getting a General Assembly resolution passed at the UN for mental health and psychosocial support. So we have the Universal Declaration, the General Assembly resolution, and this involves your new campaign for parliamentarians, on a policy level, being at the UN. How do you use these foundations, and what can we who are at the UN, there are a couple of us here, Gabe over there, Ziva over here, what can we do now to move this ahead on this policy level? Thank you.
Thank you. And sir, at the back, please.
Thank you, moderator. Dr. Humphrey Monde is my name. I'm coming from Zambia Civil Society Health Partnership, which is a lead umbrella in health. My question, Lily, moderator, is to, as we talk about universal health coverage and issues to do with mental health, there are critical issues that we need to look at. There are critical issues that we need to look at, and stigma is one of them. In my country, where I come from, we have a mental hospital where all the psychiatric patients are taken there. And I believe in other countries, that's what is prevailing. But this is not helping us in any way. All we need now is to focus on setting up rehabilitation centers for mental patients, where they have their own specific centers where they're isolated from the general public. And from the Zambian part, we're trying to mobilize our own resources from the civil society to do a rehab or a rehab center. But it would be interesting also to learn from other countries how you're doing it. Because I know where I'm coming from, issues of stigma is very, very critical. And most of these mental patients, when they're just taken there, what comes in my mind is that, this is... So I don't know, I need to learn from other countries. What are we doing? Is this something that we can work together and see how we can help in this vein? Thank you.
Thank you. And now we do have a last question, please.
Hi, good morning still. I'm Senator Amir Sabr from Egypt. This is a very important topic in my country and in my region specifically. I think you've been following the conflicts, the wars, the economic situation, the dire one, which everyone is facing. And talking about the political leadership, it couldn't be run in solitude from, or in a silo from, how the world is behaving now when it comes to the Global Fund on Health and when it comes to solidarity in solving such issues, because the toll of what is political is definitely affecting the mental health of the people. Unemployment, poverty, war and conflict are having their toll on the systems as well. So my question is, what do you think from your experience we as parliamentarians, civil society activists could do in this regard to reverse the global move on stopping funding to middle and low income countries? And the other one, given that this is the fact now, what do you think of telemedicine as a partial solution to the system implementation of providing healthcare services and mental health and well-being, and also how to check that the services delivered through telemedicine could be enough, especially to rural areas where the infrastructure is not there? Thank you.
Thank you. So now I would like to ask our panelists to briefly answer, let's say 2 questions per panelist, because we had a round of 6, 8 questions.
I've got to go in a second, so I could start, and excuse me for leaving. I had several observations and points. One was, again, around the issue of stigma, and indeed, I would agree it does extend also to, the choice of medical career, also nursing career, and many other sectors too. So all the more reason for addressing stigma as an issue that affects policy, the workforce, financing, and so on. On the financing question, this is obviously a critical time, and I think there's a lot of bad news. But what I could put as a counter to that is that it's in many countries we see real determination to change the relationship and become more self-reliant. That's really tough for many countries, right? Because they're indebted and so on. But there's a psychological kind of shift in their behavior. It's like, okay, we're done with that model. We're going to take more control of our own destiny here. And so the argument, is that to be really sustainable, financing for mental health and other areas does need to be driven by the domestic investment. Otherwise, we are prolonging, extending this relationship. Of course, there are many countries that can still benefit hugely from external assistance and support, but in a very, a very clear, targeted way, so that we don't end up in this dependency relationship. So I see a real sea change there. It's very difficult times, but hopefully, and we will see more and more countries taking on this view, this position, and becoming more self-reliant and allocating more of their own resources to the healthcare services.
Thank you.
Thank you.
Oh, let's go to Liam.
First of all, let me answer to Senator Amira from Egypt. Absolutely. In the increasing geopolitical tensions and the diminishing global health, innovative solutions, simple solutions like telemedicine definitely has a future. And by the way, India is very much relying on telemedicine at subnational level to reach the most hard to reach. And today, the American Medical Women's Association and my colleagues will be signing a global collaborator agreement on telemedicine expansion and reaching the healthcare providers and bridging the knowledge gaps and capacity gaps through telemedicine, absolutely. And this could be also something when we speak about Spanish experience, for example. I would very much request the Spanish Ministry of Health representative to provide your data to the UNITE Secretariat Mental Health Policy Desk, because we look for very specific data, evidence, and country experiences. So please share with us. And the national mental health regulations might be exactly what we can prove and test and share the experiences about. And the second issue I also wanted to address is stigma. And the audience may think that we're running from one meeting to another as policymakers, delivering some beautifully structured buzzwords, but if I personally can associate myself with any of the health conditions, it's the mental health. Mental health affected my life substantially. It left me in the age of 28 with 2 young children. And that time, speaking about seeking care or questioning that there might be some issue was so unacceptable in our families and communities that till today, that is my biggest mistake that is irreversible. But building on that experience, my dear brother, who is an extremely intelligent lawyer, he's one of the best professionals, he is affected by bipolar disease. And this time we were bold, this time we didn't care, this time we tried everything to help not only him, but the whole family, because when mental health is in the family, it affects everyone. But believe me, learning more about the condition and seeing the change as you try to seek help and treatment and seeing that you are bringing back your beloved person, and through very simple solutions, we're literally talking, if a diabetic person needs a daily insulin supplementation or other medication, we are talking about regularity of very simple treatments and family support systems that can prevent any escalation of conditions. So it's a very challenging road, but extremely rewarding. And today I am so grateful to my brother because he really helped us. We, the whole family were united, and he's one of the most decent and, foundational person who speaks openly about his condition. And we learn to overcome stigma by knowing more. And believe me, once you overcome the fear of unknown, the stigma disappears.
Thank you. Dr. Rappel, we do have also 2 questions specifically for you.
Yeah, Dr. Rabula, I think there's an online question directly for you asking, like, how do we embed practitioner perception awareness into UHC workforce frameworks so implementation reaches all the way to the first human moment of contact? The Senito framework addresses exactly this layer perception before pathology, before clinical training begins. Clinical training begins, yes. That is the question.
So I just want to make sure I understood your question. How do we integrate training?
I think how do we integrate practitioner perception into training? I mean, how do we perceive the real issues of the person?
Okay. Thank you for that question. And I'm going to address the one also about how health workers can connect with the politicians and decision makers so that decisions are made based on the needs and what health workers see as relevant for their work, and connecting with the commitments made in New York and the launch of UHC, etc. I think all these are symptoms of broken communications or not sufficient engagement, if I want to put it positively. We created silos among ourselves that shouldn't be there, and we are looking for extra solutions to address them. But I think we don't need technology. We don't need anything extraordinary for us to be able to speak to the decision makers and the politicians within our own countries, because the systems have been built in such a way that we should talk to each other. I want to believe that within the Ministry of Health, there are opportunities for health workers to meet with the top leadership of the ministry. And those opportunities should be taken to give feedback on what is affecting our work and how that is implemented. Probably accountability systems are the most broken ones, because you raise your concerns, but then how do you help leadership accountable to the health workers? Maybe this is where we need to do better work. And as part of the reform, I keep on going back to the reform. We are saying that our ministries of health have been more accountable to the donors than internally, domestically, because they were busy with so many demands for monitoring, evaluation, reporting, etc., to account for the money they receive. So I think if we try and then get better systems operating, probably the decision-making leaders will have more time to listen to the people. The same for parliamentarians. Because they need to be elected, they have to be close to the communities and listen to what the people are saying. Now, to go back to perceptions from health workers into training curricula, I think that's critically important, because if training curricula are not responding to the needs of day-to-day work, then they are not helpful. And I want to believe, again, that the health workers need to reach out to academia, need to reach out to WHO, who does a lot of training modules, and make sure that what their lived experience on a daily basis is reflected on the training modules, because the diseases are evolving, the world is evolving. People are also absorbing and then having different ways of responding to disease, and we need to adjust the training modules accordingly. And just to close, I think we need to take mental health out of the highly medicalized system where it is, because essentially I think we need social systems around to contribute to improve people's health. And that's a conversation that I believe we should have in the right place. Thank you for the
Thank you so
opportunity.
much.
Jacob has asked me to conclude in 45 seconds. So, but I think she has one question. Maybe, I don't know. So it's okay. Okay. So see, the thing is, the expertise is not limited to here. All of you have tremendous expertise, and you have raised many important questions. And of course, many of you could not raise the questions. So my observation is that this dialogue has to continue, and you need to convene this dialogue in your own context, and we need to listen to each other, and this is important. And this, it's not sufficient time. We need to extend the space where you can listen, where you can continue to have the dialogue, and identify the gaps and equip each other and monitor. Thank you.
Thank you so much. And now I would like to ask Pradip to conclude the session.
Thank you, Jakob. I think we are running out of time, so it was great discussion we had today. It is something like very important time, as we are having upcoming global health architecture reforms, and next year United Nations high-level meeting on universal health coverage and many more. So thank you for joining. Thank you for actively involving all the in-person and online participants. I want to thank especially for all the panelists on behalf of the United Parliamentarians Network of Global Health and the Global Mental Health Action Network. Thank you, everyone. Let's keep the discussion going.
Thank you all.
Thank you very much.